Hypothalamic-Pituitary-Adrenal axis. Physiology of the HPA axis. Cortisol secretion is rigorously controlled by the HPA axis, which works with a tethering mechanism of negative feedback at all levels. Stress stimulates the hypothalamus to increase the secretion of CRH, a hormone that stimulates specialized cells of the anterior pituitary gland to release ACTH. ACTH reaches the adrenal cortex and stimulates the production of steroids, such as cortisol. Cortisol contributes to the restoration and maintenance of hemostasis during stress, counteracts many steps of the inflammatory response. It stimulates gluconeogenesis and glycogenolysis, and maintains vascular tone and endothelial integrity. The adrenal cortex secretes approximately 20 to 30 milligrams of cortisol daily, reaching serum levels ranging from 5 to 24 g/dl. Under stress conditions, secretion may increase 10 to 12-fold. Once released, almost all of the cortisol, 90 to 95%, in circulation is bound to plasma proteins, cortisol-binding globulin, CBG, and albumin. However, only the free fraction is bioactive. Glucocorticoid exerts an anti-inflammatory action through two different mechanisms: transactivation or transrepression. In critical illness, inflammatory mediators activate the HPA axis in such a way that the pulsatile pattern and the circadian variability of cortisol secretion are lost. The resulting hypercortisolism is initially protective, increasing gluconeogenesis, maintaining intravascular volume, and modulating the inflammatory response. Cortisol levels remain high throughout the critical illness, despite the reduction in adrenocorticotropic hormone, ACTH, suggesting the participation of other pathways in this regulation. Once the critical phase of the disease has passed, cortisol levels tend to return to normal. The maintenance of hypercortisolism, however, seems to be associated with long-term complications, hyperglycemia, myopathy, post-traumatic stress disorder, and poor wound healing. Critical illness-related corticosteroid insufficiency is a dynamic and usually reversible condition characterized by inappropriate cellular activity of corticosteroids for the severity of the disease. It manifested by persistently elevated pro-inflammatory mediators. The clinical manifestations of SIRSI are a consequence of an exacerbated inflammatory response. Hypotension refractory to volume resuscitation requiring vasopressors is a hallmark for suspicion. The laboratory may show eosinophilia and hypoglycemia. Hyponatremia and hyperkalemia are uncommon. The use of intravenous hydrocortisone is recommended in cases of septic shock with poor response after volume resuscitation and vasopressor therapy, with dosages not exceeding 400 milligrams per day. Dexamethasone should be avoided because of the possible immediate and prolonged suppression of the HPA axis. Fludrocortisone is dispensable when hydrocortisone is used for its intrinsic mineralocorticoid effect. And progressive weaning is suggested by the risk of increased pro-inflammatory mediators and hemodynamic deterioration with abrupt withdrawal.